Good afternoon. My name is Jason Browder. I'm giving a presentation today on evaluation of thoracic pain. I apologize for any errors in recording. This is the first time I've done this using Microsoft PowerPoint. I chose the topic of thoracic pain in part because I'm sick and tired of seeing lectures on low back pain. And so I figured that given the audience that VOMA has would include physicians that are not interested in osteopathic manipulation, that might be cardiologists, emergency room physicians, maybe OBGYNs, etc. And they have patients come into their office with thoracic pain. And I figured I'd give you at least a medical approach for evaluation of these patients. And then I would give you osteopathic nomenclature, diagnosis, and treatment as we go along through the lecture. Let's continue. So me, I'm a outpatient internal medicine doctor. I do regenerative injections, such as prolotherapy and PRP in my office in Newport News. I'm a zealot of osteopathic medicine, and I wrote a textbook which we're about to see on that. I'm also a Virginia Tech preceptor for 3rd and 4th year medical students. I've been an educator of VCOM since 2014, and prior to that, during military service and training, I'd worked with HPSP medical students for internal medicine in outpatient and inpatient settings. I'm also retired since 2017 from hospital work, which I did from 2003 to 2017. So disclosures, I've written a book entitled Introduction to Manual Medicine, an Osteopathic Perspective with my good friend Paul Johnson and Hollis King. Hollis King's the most published osteopath in the history of the profession. If you want to take a moment, you can download the book right now. Most of the information in this lecture is going to be coming from chapters 1 and 2, so basic principles, and then thoracic spine chapter. I'll give you a second to download it, and then we'll continue. And I do want to mention before we go on that this text is copyrighted, and so any images that are in this lecture, I have the copyright license to use. Anyone who wants to use them in their future lecture should contact me regarding that. So our lecture outline, again, it's on thoracic pain. We're going to talk about our initial evaluation. So you're in your outpatient clinic or in the ER, and you have someone come with thoracic pain. What are the steps you're going to do? We're going to talk about things that I call musculoskeletal masqueraders. And then we're going to go over the osteopathic manual medicine for diagnosis and treatment. So initial evaluation. So I can't stress this enough, and I stress this to my medical students. We are physicians first. We are not manipulators. We don't just have a patient come in to our office and we start manipulating them. We make sure we go through our normal history, physical examination, and in this initial evaluation, getting a history, not just a SOAP note, getting allergies, medicines, surgeries, past medical history, family history, social history is extremely important. I see so many people that come in with, for instance, hypermobility, and if I just lay them down and start examining them, I might miss this. And so we have this whole subset of population, and probably 1 in 5 women that I examine for back pain have some form of hypermobility, be it Ehlers-Danlos, type 1, 2, or 3. And if you unknowingly start treating these people, you can hurt them. So again, history, history, history. We're a physician first. So our red flags for thoracic pain: trauma, osteoporosis. And there's an interesting story I'll say at the end of this. Known cancer. Your patient has cancer. You ask them, Do you have cancer in this area where you have pain? Of course, they don't know most of the time, and you need to do some digging to figure that out. B-type symptoms, right? Itching, night sweats, weight loss, things that point to stuff like lymphoma, leukemia. You need to ask these questions. Pain out of proportion. In other words, the patient is reporting a 9 out of 10 pain in their thoracic spine. That's not typical of musculoskeletal pain, right? I mean, that could be anything from dissecting aneurysm to something much more clinically horrible like a torn muscle than something like somatic dysfunction. Pain without mechanism of injury. Keep this in mind. The patient comes in, and I see this all the time. Referral from their primary care doctor saying pain in the mid-thoracic area, and they don't have a mechanism of injury. There's no car wreck, there's no fall, they didn't get kicked in the back by a horse. What caused this? Red flag. Before I go on, I want to go back to osteoporosis, and I think this is a good lesson that I share with my students, right? I had a patient come in. She had had a history of breast cancer with a radical mastectomy on her left side, local radiation to the anterior chest wall, and I had this patient lying prone. I know she has osteoporosis. I'm probably exerting 10 pounds of pressure on the posterior, she's prone again, on the posterior aspect of her thoracic spine, and crack. It feels like I'm doing CPR. And all of this because she has osteoporosis, and I applied 10 pounds of pressure. Certainly an unexpected outcome, but nevertheless, these things happen. This has happened to me. And it also could happen to you. So without taking this history, then you might miss this or might not know what's going on. And then again, physical exam. And I'm not talking about just an osteopathic exam. I'm talking about doing reflexes, your neuromuscular exam, reflexes, sensory, strength testing, looking for deficits, depending on the history, cranial nerves, right? And then, depending on the history, again, cerebellar dysfunction. But at a bare minimum, reflexes, strength, and sensory. And then, they're having thoracic pain. So you better whip out a stethoscope and listen to their heart and lungs and make sure that you can hear, good breath sounds, normal heart tones. You also need to make sure that you're palpating locally over the area, that you're, taking off the any garments so that you can look at the area in question where there's pain and make sure that they don't have a rash, shingles, anything of the sort in that manner before you proceed with any other thing. So one of the most important things of this lecture, besides the red flags in terms of your initial evaluation, are the 6 acute life-threatening causes of chest pain. And I don't care what kind of physician you are, this is worth memorizing, this is worth learning. And when people come in, you need to go through a triage for evaluating the 6 causes of acute life-threatening chest pain, if nothing else, just to satisfy your own left brain so that you can say, yes, I've evaluated them for these causes. And I'll give you a hint here at the end of this of how you can evaluate this quickly if need be. Acute coronary syndrome, right? They come in with chest pain. You're concerned about heart stuff. You better be listening to the heart and lungs, getting an EKG, depending on your setting, either getting cardiac enzymes in the ER or sending them to the ER for evaluation of acute coronary syndrome. I do think it's inappropriate for people to be ordering cardiac enzymes in the outpatient setting. I've had this happen to me where one of my partners ordered cardiac enzymes, and guess what? They come back positive from our lab at 10 at night, about 8 hours after the initial evaluation. Well, what do you do with that, right? There's a whole conundrum. Number 2, thoracic aortic aneurysm. Again, the patient comes in with severely elevated blood pressure, perhaps 170s, 180s, or above systolic. Perhaps you better be checking a blood pressure on each arm, checking pulses on each arm, making sure that they're symmetrical in your outpatient setting, just to satisfy that they do not have this problem. Tamponade, again, getting an EKG, looking for low voltage, pulsus paradoxus. Pneumothorax, do they have a history of trauma to the chest wall? Can you hear breath sounds on both sides? A simple chest x-ray will help evaluate you for this. Pulmonary embolism, again, from the history. Oh, I had a swollen leg. I just drove across country. There are whole calculators for pulmonary embolism that you can use based on pretest probability. But again, in the outpatient setting, do you order a D-dimer? Do you order a DVT ultrasound? If your suspicion is high for pulmonary embolism, you better start ordering the diagnostic test, which we'll get to in a second. And then esophageal rupture. This is, at least in my clinical experience, extremely rare. I've never seen this in inpatient or outpatient setting. But again, if they come in with a history of retching or ingestion of some toxic substance that would erode the esophagus, you could consider this. Now, for anyone wondering, what is the quick and easy way of evaluating the 6 acute life-threatening causes of chest pain? Number 1, EKG to rule out ST elevated MI. Number 2, a CT angiogram will evaluate aortic aneurysm, tamponade, pneumothorax, pulmonary embolism, and esophageal rupture with pretty good sensitivity. And so, in the ER setting, ER doctors order this all day long. But for you primary outpatient physicians, if you can't do the evaluation and can't rule these out in your outpatient setting, you need to send the patient to the ER for evaluation. You do not start evaluating these people for biomechanical and somatic dysfunction without evaluating, or at least thinking of these things. So, musculoskeletal masqueraders. I'm going to read a quote from Lawrence Jones' Counter-Strain book. Patients with a history, and this is in his own words. Patients with a history of myocardial infarction may suffer another episode the day after a traumatic or an atraumatic treatment, that is, a treatment of OMM. This occurred twice in my 60 years of practice. Now, when I read this as a medical student, and I was studying with Lawrence Jones' progeny, or the physicians that he had trained, and I'm studying with these guys, I read this and I highlighted it. And I just remember thinking to myself, this is so bizarre that he treated these people with OMM and then the next day they have a heart attack, or 2 days later. And so in my experience and opinion, I think that these patients were actually having viscerosomatic reflexes, right? And that Jones was so tuned in to the biomechanical aspect that he forgot to consider the 6 life-threatening causes of chest pain, and that this patient might have a viscerosomatic reflex. And I know that you all love viscerosomatic reflexes. These are the things you memorized for your boards, right? And then you forgot all about. Well, I see them in my clinical practice all the time. So let's get to the viscerosomatic reflexes. And again, I think that the main thing to remember when you're going to think about, is this a viscerosomatic reflex? Pain without mechanism of injury, right? The patient comes in with thoracic pain and they have no mechanism of injury. So viscerosomatic reflexes can come in 2 forms, right? Parasympathetic or sympathetic. The parasympathetic are they cranial or are they sacral in nature? And if the patient is complaining of, for instance, a urinary tract infection, and they're having pain around the sacral area, you need to be thinking, hey, this patient is having a parasympathetic viscerosomatic reflex, likely from the bladder. The primary problem is not a sacral somatic dysfunction. The patient is getting a reflex of pain from the bladder to the low back and sacral area. Again, the sympathetic mediated viscerosomatic reflexes. Again, did Jones miss this one? T1 to 5, right? And I'll demonstrate how this happens as I understand it from Frank Willard's lectures. And for those of you who don't know, Frank Willard's a neuroanatomist from New England. He gives lectures every year at the AAO conferences, and watching his lectures was very helpful for me and help in understanding these and putting it together for the book. So again, let's start over here with the heart. The sympathetic innervation for the heart is T1 to 5. So the sympathetic chain ganglion, T1 to 5. The heart is undergoing some stress, anaerobic metabolism, MI, right? It reflexes pain into the sympathetic chain ganglion. This goes up to the brain. And when the brain reflexes out the signal of pain, it goes to T1 to 5, right? That goes back to the heart, but it also goes to all the structures innervated by T1 through 5. If we recall anatomy, the upper extremities are innervated by C5, 6, 7, 8, and T1. And so everyone's seen those TV shows where the guy grabs his arm and he goes, "I'm having a heart attack." And you just kind of look at him bewildered, like, why aren't you grabbing your chest? It's because of this viscerosomatic reflex that these people get these pains. This is not a referred pain. Okay, referred pain is I push on an area of the body such as the glute and it sends a pain signal out into the lateral aspect of the thigh, right, over the greater trochanter. A viscerosomatic reflex is neurologically mediated through the central nervous system, and so that is the difference. So again, all of these are neurological in nature. Now, the most common one that I see in my practice is from the esophagus. I have people coming in, no mechanism of pain. They have pain in the mid to upper thoracic area. It is almost ubiquitously acid reflux with GERD, and with relation to GERD, when someone has acid reflux occur, they will get pain in their esophagus that'll last 3 to 7 days, depending on the person, and it will be constant. And it will take, using proton pump inhibitors or some other medication, about a week to 2 weeks to go away. So many times people come in, no mechanism of injury. I rule out red flags. I rule out the 6 causes of chest pain, in my office. And then I might say, oh, you're having reflux. Why don't we try a proton pump inhibitor and see what happens, right? Proton pump inhibitors are very specific to the stomach, right? They're not causing a lot of systemic effects, just locally to the stomach and anything that's secreting hydrogen ions. And so we give them a trial of it. If they get better, bada bing. We're treating the underlying problem here. We're not just looking to lay them down and start cracking on their thoracic spine. Now, one other thing I'll say about viscerosomatic reflexes, and it probably took me 10 years to figure this out. If I start treating something, with a direct or indirect treatment, it really resolves within 30 to 90 seconds, depending on the treatment modality, but certainly no longer than 2 minutes. There are times that I sit there and I'll treat something and it's going on 5, 10 minutes. I read in one of Robert Fulford's books that he said, if a treatment requires 30 minutes, you stay with it and treat it. Man, I'll tell you, in my clinical experience, if it's taken more than 2 minutes to treat using like strain counter strain or some other indirect modality, it is a viscerosomatic reflex, and you need to start, turn that left brain back on and start thinking, what is causing this? All right, that is just a clinical pearl for you. I guess people perform manipulation. Okay, so now we go into the diagnostic portion of this. We've ruled out all of our red flags, history, physical, using our left brain as physicians. And now I kind of tell people that I'm schizophrenic. My wife says, yes, you are, but clinically speaking, schizophrenic, right? I satisfy my left brain by evaluating the patient as a physician, and then I turn that off and I start becoming more creative with my right brain in evaluating and diagnosing for somatic dysfunction, right? The areas that we're using, for those of you who haven't looked at OMM in a long time, our reference point for determining the rotation and position of a vertebrae, be it cervical, lumbar, or thoracic, is the anterior superior aspect of the vertebrae. Okay, just as our reference point. The things that we're going to need for diagnosis are the transverse processes of the spinous, of the vertebrae, and then the spinous process. Clinically speaking, when people say, oh, this is around T3, T4, again, our reference for T3 is the spine of the scapula, T7 is the inferior aspect, and then again, you can feel that last floating rib connect to the T12 vertebrae. That gives you an idea of where you are clinically. So we all learned in medical school Fryette's principles. And at that time, they called them Fryette's laws. And so I'll review these briefly and then have a further discussion about these, because these are still taught in osteopathic medical schools. And I think that they should continue to be taught for historical reasons. But I think that in terms of education and what ECOP, Educational Council of Osteopathic Principles and Practice, is doing, they're holding on to these, and they're not updating students with new data, new information. So let's go over these briefly in review. So when in neutral, right, side bending produces rotation opposite the data side bending. And if you remember from school, we denote this neutral side bending, in neutral side bending rotation, right, NSR, because side bending comes before rotation. When in flexion or extension, side bending and rotation occur in the same direction, right? So we denote these ERS or FRS, right? When it's in neutral, it's NSR, right? So extension, rotated side bend, or flexed, rotated side bend. And flexion and rotation occur in the same direction. So in other words, it's rotated right, side bent right. It's rotated left, side bent left. And then principle 3 was actually first talked about by a man named Nelson in 1948. And this basically says, and it's kind of common sense, that if I limit the motion in one plane, it limits the motion in other planes. So recent studies have shown that motion in the thoracic spine, cervical spine, and lumbar spine don't exactly follow Fryette's principles. And in fact, you can have, in flexion, you can have side bending and rotation that are opposite, right? Or extension, or in neutral, you can have flexion and side bending that are to the same side. And so this creates a problem clinically, that I'll discuss here in a second. But there's some references back to the studies that kind of prove that. And so the correct diagnosis, why does it matter? Well, as I alluded, this is still, Fryette's principles are taught in school still. Well, in clinical practice, I remember before I had read those studies, I would see side bending and rotation that are to the same side in neutral, or that are opposite, right? Or what we call contralaterally coupled in flexion or extension. And this is important because I remember being in our OMM lab as a medical student and saying, oh wow, this is in flexion and the side bending and rotation are opposite. And one of the OMM, undergraduate helpers said to me, well, that's not possible. So you must have the wrong diagnosis. And I remember thinking to myself, I really suck at this. My hands are terrible and I can't feel anything. Well, here's the problem. perhaps I was right, and these studies show it. But because we continue to learn Friat's principles and that they are true, you know, I think that I have the wrong diagnosis when in fact I have the right diagnosis. I'm sure other people had similar experiences in their schooling. And so what I would encourage you to do is read my textbook, and we address this in there. So coupling, right? That is our side bending and rotation to, how are side bending and rotation interrelated? Are they the same side or are they opposite, right? If they're coupled to in other words, if side bending and rotation are to the same side, we call that ipsilaterally coupled. If side bending and rotation are to the opposite side, we call that contralaterally coupled, right? So we are going to use the following example throughout the remainder of this lecture to discuss the thoracic spine, and give examples of treatments for 4 different modalities. So using the example T6 ERS left, again, remember that this denotes that rotation and side bending are to the same side, or what I term ipsilaterally coupled. So in T6 ERS left, what's really happening here are the facets are locking on the left side of T6 in relation to T7. Remember, we name a somatic dysfunction of the spine. If we name T6, we're talking about T6 in relation to T7. And so the facet pair is locked closed here. And so a lot of people have asked, why does that happen? Well, these tiny little muscles, the intertransversii and the interspinalis muscles, will spasm and lock shut, and they will not allow these facets to open. And that is what holds and maintains somatic dysfunction, according to Philip Greenman. So here's a lateral view, right? And if you'll recall, I remember one of the most confusing things when I was a first-year medical student was, why on God's green earth do we name a somatic dysfunction that is extended when it is in flexion? And here is why. Here's our neutral view, right? Our beginning view. Here's T7 and T6. T6 is extended. When the patient extends back on your exam, so either if you have them actively extend backward, or even if you passively extend them, this will not be detected because the vertebrae is already extended. So it will not be detected. It will be detected again in flexion. When they flex forward, it will stick out like a sore thumb, and you'll say, wow, the vertebrae remains in an extended position. And again, it will be rotated left in this example. And so here's T7 and T6, obviously exaggerated in relation to that. But again, we're naming it according to the anterior superior aspect of this vertebrae. So in my opinion, using Friat's principles to say, hey, if it's in neutral, side bending and rotation are going to be opposite. And just determining whether the patient is rotated right or left is inaccurate. Just as inaccurate as it is to go along with Friat's second principle and say, hey, if side bending and if rotation is determined in flexion to be rotated left, then it must be side bent left. And so here's a list of steps that will correctly allow you to evaluate the cervical, thoracic, and lumbar spine, and independently identify flexion and side bending and rotation. So step 1, have the patient sitting in front of you. You put a thumb posteriorly on their transverse, or on their facets on the right and left, and you examine them as in that previous picture. They go into flexion. You feel for asymmetry, either right or left. They go through neutral and then back into extension, and you feel right and left to see if there's any abnormal rotation. So again, when they are in flexion, in this example for T6 ERS left, that is when you're going to notice this vertebrae is an extension, right? Because you're going to notice that one of the facets is posterior. Step 2, identify rotation. You are going to feel the facets and or the transverse process on the left posteriorly, okay? So far, this is just like what we learn in school. Step 3. This is the step that really kind of drives home, and it actually makes a lot of sense. Now, if I have a patient sitting in front of me, just like this vertebrae over here, just like this stack of vertebrae, T6 and 7, and the patient is rotated left, and I want to know, are they side bent left? If the patient is sitting there and I take them and I move them, so passive movement, and I side bend them left, if that vertebrae remains rotated left, then I know that the vertebrae is side bent left and rotated left. Okay. Conversely, if I rotate them, if I side bend them to the right, and the vertebrae starts reversing, right? In other words, it does not remain rotated left, then I know that I'm changing it. And actually, what you're doing in that instance is putting the patient into the treatment position. So if it's rotated left and side bent left, okay, and then you go to move the patient, and that is your positional diagnosis, right? ERS left. And if you go and you side bend them to the right, that vertebrae will actually switch its rotation. It'll start rotating toward the right. Okay. Now, conversely, if you take the patient and you side bend them right, and the vertebrae remains rotated right, then we know that they are rotated right and side bent left. Okay. It may take a while to chew over. Again, read chapter 2 of my book. I also talk about this in chapter 3 with the lumbar spine. So treatment. I'm gonna in the book we talk about different types of treatments, specifically direct and indirect, and I'll briefly review what they mean. All right, this is straight from the American Academy of Osteopathy glossary. So a direct method, an osteopathic treatment in which the restrictive barrier is engaged and a final activating force is applied to correct somatic dysfunction. Okay, so in chapter 1 of my book, I had this is figure 6, and what we have here is just basically a theoretical model of, we'll say in this instance, rotation or side bending. And here we have neutral, right? We have our physiological barrier, our elastic barrier, and an anatomic barrier, right? And so in rotation to the right, we have lost range of motion, okay, in our previous example, because the patient is rotated and side bent to the left. And so here's our barrier of somatic dysfunction. So with regard to treatment modalities that are direct, HVLA, right, pop and crack, people think that this was what AT still learned from Native Americans. Again, and then muscle energy. This is developed by Fred Mitchell, who gave us this naming system from Michigan State. And I'll go over in turn in a second the kind of principles of those. So the 4 principles of any direct treatment, whether it's myofascial release, or it's muscle energy, or HVLA, etc., is that you engage the barrier. So if your diagnosis is extension, rotated left, side bent left, you are going to reverse all of this. Place the patient in flexion, rotated right, and side bent right. You're going to set a fulcrum at this level. And when you set the fulcrum for T6 FRS right, you're actually setting the fulcrum on T7, right? You're going to use a lever. You're going to use the spine. And people talk about long levers and short levers, right? The easiest explanation So the simplest explanation of a lever, a short lever, would be I use a thrust on the spinous process, right? A long lever would be I flex the spine down from, the occiput all the way down to T6 and set my fulcrum at T7. That is a long lever. And then force, do I do an impulse or a thrust maneuver? Do I have the patient turn, as in muscle energy? But again, these 4 principles are the same no matter what direct method that you use. So indirect methods. Manipulative treatment in which the restrictive barrier is disengaged and the dysfunctional body part is moved away from the restrictive barrier. So again, here we have our model for somatic dysfunction. Again, here's neutral, physiologic, elastic, anatomical barriers. Here's our lost range of motion, right? Out here is where we're going to be positioning the patient at a position of ease. So in the textbook and in this lecture, we use 2 methods of treatment versus functional procedures. And then the second is strain counterstrain. Strain counterstrain was introduced by Lawrence Jones, and he spent 20 years developing this before he brought it forward. Uses a series of points called tender points. They're located all over the body, and the idea is that you put them at a position of comfort and then either hold them there for 90 to 120 seconds. For functional procedures is the term we use in our book because there's some confusion as to this. Functional methods was a method of indirect treatment. So functional methods by William Johnson. My instructor at Pikeville was Ed Stiles. He would talk about just functional and never use the term functional procedures or functional methods. And effectively, the methods are very similar. The difference being is that Ed Stiles figured out that if you could place the patient in their positional diagnosis, right? So T6 ERS left is the positional diagnosis. Then you could fine-tune that and begin the treatment. William Johnson talked about the 6 degrees of freedom. This meant by placing the patient in a position of ease that you would put them through passive rotary tests of flexion extension, side bending, and then axial rotation and translatory tests of left and right, anterior, posterior, and then cephalad or caudad positions. And that's how Johnson determined the position of ease. So he would move through those 6 planes of freedom. And so Ed Stiles figured out that, hey, if I diagnose someone with somatic dysfunction that is ERS left, if I place them ERS left at that level, then I can fine-tune that and begin the treatment. And I will say clinically, he's exactly right. And that's exactly what I find as well. And so by combining kind of the Johnson and Stiles method, in this book, we discuss them as functional procedures. So the principles of indirect treatment: begin at the position of ease, aka the positional diagnosis. So if the patient is diagnosed T6 ERS left, place them T6 ERS left. And then at that position, you either hold, as in strain counterstrain, or you add a compressive or distractive force. And then you just wait for the treatment to resolve. Again, in strain counterstrain, that would be 90 seconds or 120 for ribs. That's the textbook answers. I can say that, and clinically, this occurs probably in a shorter time period. And then for functional treatments, they usually resolve within a minute, 30 seconds to a minute. So we're going to talk about direct treatments. We're going to go back to them now, and we're going to talk about muscle energy. So in the textbook, we give this example for T6 ERS left. And so I'll just describe this. This is Paul Johnson, and this is me. And so what Dr. Johnson has done here, he's placed a fulcrum at T7. Okay? He's got me in flexion. Again, he's going to reverse this. He's going to put me F, flexed, rotated right, side bent right. He's got me flexed. He's already got me side bending to the right, and then he's got me rotating right with that fulcrum. He flexes me down with a long lever, so flexes way down to a long lever. He's got his fulcrum set right here, so the motion stops at T6 to T7, and all the motion that's going to occur occurs at T6 to T7 at that segment. And then applies a force. So he has me turn left, or towards the center of my body. I relax. After 5 seconds of motion, he repositions me to the next barrier, further flexing, rotating right, side bending right, and then again ask me to rotate toward the middle for 3 to 5 seconds, relax, and repeat. And at the end of it, of course, you recheck. So very simple. If there's anything worth learning, if you're not doing manipulation and you want to get back into it, I think that muscle energy is the simplest thing. I use it all the time. I probably use it on 60 to 70% of my treatments, and it's extremely safe. Now, HVLA. I do HVLA. However, I'm very selective, okay? And I'd like to say that when I do HVLA, I'm doing it with the mindset that I am treating something that is fibrotic. There is some scar tissue, and I want to mobilize, and for instance, this segment, because, you know, T6 with relation to T7, those little intertransversi muscles have been tight so long that it's created scar tissue or fibrosis in the area, and I just can't break it up doing normal stuff. But you've got to have a good level of confidence and sophistication to get to that point, or just be a cowboy. So again, position against a restricted barrier. So we're going to place the patient flexed, right? Flexed, side bent, right, rotated, right. Dr. Johnson's got a fulcrum here at T7 that he's using with his, I guess his first digit in his hand is the way he likes to do it. And then again, a lever, the long lever from the occiput all the way down to T6, and then an impulse directly down at the table. Now, what he's doing is he's doing an impulse on T6 of the vertebrae in relation to T7 to reverse that extension. Okay, the vertebrae had been FRS left, right? Then the impulse would change, in a more cephalad direction. So our indirect treatments, functional procedures. Again, begin at the position of ease. The diagnosis is T6, ERS left. We are going to place the position T6, ERS left. Okay, so you can see he's got me extended, side bent left, and rotated left, and then he fine tunes it. What he's done here is he's placed his hand down on T6, so he's monitoring T6 on T6. Again, with the direct treatments, you're going to be placing a fulcrum there on T7, but he's T6, he's monitoring the segment. He's got side bent and rotated right, and then he's adding a compressive, side bent rotated left, and then he's adding a compressive force through the shoulder down into the vertebrae, and then he allows it to unwind. Interestingly, William Johnson, when in this position, would just have the patient take a breath in, out, and then reposition to the next position of ease. Have him take a breath in and out, and then fine-tune those 6 degrees of freedom as he goes along. I find that for beginning level students, that this is an easier method of treatment than Ed Stiles' method, which requires a lot of balance and a lot of skill on the practitioner side. So again, you can employ that Johnson's method of inhalation and exhalation and repositioning at the position of ease. And again, this is a very safe method of treatment. You're not going to hurt anyone doing this as long as you've ruled out the red flags and the 6 causes of life-threatening chest pain. Strain, counter, strain. So begin at the position of ease. Again, this works equally as well. And you can see here this strain, counter, strain chart. And of course, this is nebulous to most people. Why memorize all this? Again, it's going to be a tender point on the 6th vertebrae, and then it's going to be on the left side. Okay? because side bending left and rotating left are going to contract those interspinous and intertransversii muscles that are maintaining this. And once you shorten that muscle, that tenderness goes away. So Dr. Johnson's got me extended, side bent left, rotated left. That shortens that muscle, and the tenderness should resolve. I think it's very interesting in Jones's book that he talks about rogue points. And in that he says, hey, about 10% of these points, you'll think that the position is going to be side bending and rotating to the left, but about 10% of the time you side bend left and rotate right. And so to me, what that means is that you have a misdiagnosis. Again, you're using Fryette's principles and assuming that the side bending and rotation are ipsilaterally coupled, but I think that they're contralaterally coupled for these rogue points. And it's interesting as we learn more in the profession is, do we continue to perpetuate misinformation, or do we challenge it with the evidence that we have? And then again, in this position, we don't add a compressive force, we just hold it. And you wait, and it's boring. And you make a funny joke. And then you slowly move the patient out of position for this after about 90 seconds. That's the book answer, right? And then you recheck the tenderness, and many times it will go away. So regarding this lecture, takeaway points. I can't emphasize this enough. You are a physician first. Don't ever forget that we are not manipulators. I've worked with people, I've seen them do this to where the patient comes in, they take a 1-minute history, they don't really examine them, and they just lay them down on the table and begin treatment. I can think of a time when I got a consult when I was in the military, and a young lady came in, and she was active duty, and she was having, substernal chest pain. She's 26 years old. So, you're thinking to yourself, hey, this can't be cardiogenic in nature. And I asked her, do you have any history of trauma? Rule out all the red flags. It's just something's not right. This chest pain came on gradually over 6 to 12 months. And so I get a chest x-ray. And there's a widened mediastinum. And we get a CT. And she has a giant thymoma. OMM is not going to fix a giant thymoma. This requires, the cardiothoracic surgery and perhaps oncology or radiation to resolve this. OMM is not going to resolve this. Likewise, patients coming in with visceral somatic reflexes. You're not going to fix GERD with OMM. And I think, maybe one of the other hallmarks that I see when I treat people is if I treat someone with GERD with OMM and they come back to me and I say, how long did that treatment last? And they say, the treatment lasted about 6 to 12 hours and then it slowly came back. Either I haven't got the right somatic dysfunction, or I'm treating a visceral somatic reflex. And then again, combining that with the history of thoracic pain that came from no mechanism of injury, keep that in mind. Again, rule out the 6 causes of life-threatening chest pain. In this instance, we talked about, acute coronary syndrome, PE, dissecting aneurysm, pneumothorax, Voorhees tear, and tamponade. And so I want to emphasize, there are simple tests that you can do in the ER setting, right, such as an EKG and a CT angiogram of the chest to rule out these. You get serial cardiac enzymes, 6 to 8 hours after the initial, depending, and I guess even with the newer high sensitivity cardiac enzymes, you can get them within 2 to 4 hours. You can have these evaluated and ruled out. In the outpatient setting, I do not recommend people order cardiac enzymes. If you're trying to rule out a PE in the outpatient setting and you order a D-dimer, if they're having acute chest pain that's happening that day, you're probably best to send them to the ER and not get a D-dimer, unless you think the condition is chronic PEs. Takeaway points for the direct treatments, as well as the indirect treatments, is consider that Fryette's principles are not correct. Again, they've been proven incorrect for quite some time, and refer back to chapter 2 in my book for a new method and rationale of diagnosing and treating that. Again, direct treatments always begin at a restricted barrier. They use a fulcrum, lever, and force. It doesn't matter if it's HVLA, muscle energy, myofascial release. Indirect treatments begin at a position of ease, right? AKA the positional diagnosis. So T6, ERS left is going to be positioned T6, ERS left, and that is just the easiest thing once you figure that out for starting, for a starting point for functional procedures for strain counter strain. You put them in that position and then you just fine tune it. All right, and then add a compressive or distractive force, or just hold the patient. So now we're going to go over some review questions. These are available in Introduction to Manual Medicine, Osteopathic Perspective on pages 72 to 74. The first 4 questions are of first order. The last one is a third order question. Let's begin. The positional diagnosis of vertebral extension is made during active patient extension, during active patient flexion, while the patient is in neutral. So this should be made while the patient is in flexion. Type 1 somatic dysfunctions are usually compensatory in nature, occur in groups of 2 or more vertebrae, produce rotation from the convexity of the spinal curve, occur in non-neutral positions. These are going to be typically seen compensatory in nature to a short leg. Sometimes you'll see this in response to things such as sacral flexions, non-neutral lumbar somatic dysfunctions. And so if you find type 1 somatic dysfunction, look for something else first prior to treating it. Answer B should be 3 or more vertebrae. Answer C should be rotation toward the convexity. D, occur in neutral positions would be the correct answer. The reference point to spinal movement this is going to be the anterior superior portion of the vertebral body. And don't forget that. Spinal segments such as T6 ERS right is named from T6 in relation to T7. According to the principles of spinal motion, which of the following would not be a plausible diagnosis? Flexed, rotated left side bent left, extended, rotated right side bent right, neutral side bent right, rotated left, and then neutral, rotated right, side bent right. So again, Fryette's principles, I put this in here to remind us that this is the textbook answer and your board answer. However, in clinical practice, as I mentioned previously, you can see any number of diagnoses, and that Fryette's principles don't hold true much of the time. Recent research has vetted that. So D would be if Fryette's principles were correct. As the patient moves into extension, he has a right posterior transverse process. So he's rotated right. Assuming the principles of somatic dysfunction are correct in this instance, the optimum direct treatment position would be. So we got to come up with a diagnosis, and then we've got to come up with a direct treatment position. Okay? So if the patient is moving into extension and you find somatic dysfunction, it'll be flexed. So flexed, rotated right, side bent right. So our positional diagnosis is flexed, rotated right, side bent right. So the direct treatment position would be extended, side bent left, rotated left. There you go. Now again, if it's FRS right, this is the diagnosis we just came up with, right? This would be the optimal treatment position for indirect treatments. So again, my name is Jason Browder, TPMG shareholder for going on 12 years now. I'm at Omni Boulevard at our flagship headquarters, right next door to the OBGYNs. I'm taking new patients. I'm available for OMM consultations, regenerative injections, including things such as osteoarthritis, I get excellent results with prolotherapy of the thumbs and knees, as well as regenerative injections for recurrent somatic dysfunction of the sacrum, which I see in traumatic events like motor vehicle accidents, and then whiplash injuries, such as in falls or motor vehicle accidents. I'm happy to see anyone you'd like for me to see. I'm also available for doing lectures and coursework, especially those of you who may want to resume your OMM careers, having taken a hiatus for a number of years. Please call or contact me should you need anything. Good luck.